On-the-scene video coverage of TCT 2012 is supported by Prodexa.
Thank you very much. It's my great pleasure to present results of our academic study of 4 high-volume PCI centers. STEMI-RADIAL is a prospective randomized trial comparing patients with ST segment myocardial infarction. I have nothing to disclose. To these days, there have been 2 big, large randomized multi-center trials comparing femoral and radial approach in primary PCI. In rival trial, there was a sub-study of OASIS 7 and only 74% of patients were treated by primary PCI. In rifle study, they enrolled patients in first 24 hours of onset of symptoms. They also include patients with shock, and radial experience in both trials was variable and crossover rate was relatively high. Objective of our study was to compare radial versus femoral approach in primary PCI for patients with STEMI in first 12 hours of onset of symptoms in very high volume radial centers where performed over 80% of primary PCI by radial. Primary endpoints was horizons, bleeding and access site complication criteria, but hematoma were evaluated as significant in case of size over 15 centimeters. Secondary endpoints were MACE, including death, MI, stroke, NACE, crossover, angiographic success, contrast volume, procedure and fluoroscopic times, and ICU stay. This is a study design. During October 2009 to February 2012, in 4 high-volume PCI centers, 707 patients were randomized. Electronically, clinical follow-up at 30 days was 100%. Baseline characteristics was well matched, and only the proportion of hypertension patient was higher in radial group. Anterior MI was presented in 40% in both groups, and symptoms to balloon time was also in both groups around 3 hours. (65% of all patients in both groups had initial TIMI flow 0 and 1. Majority of cases were performed by 6 French, 25% by 5 French. Crossover rate was low, 3.7% in the radial group and 0.6% in femoral group. Procedure time and fluoroscopy time were similar in both groups. What was interesting was the fact that contrast volume and ICU stay was significantly lower in radial group. This is the main slide of our result. 30-day bleeding and access site complications was 7.2% in femoral group and 1.4% in radial group. It means we found 80% relative reduction of this primary endpoint. MACE was similar in both groups, and together with bleeding, net adverse clinical event was significantly lower in radial group. Relative risk reduction was 58%. In conclusion, let me say that in patients with ST elevation myocardial infarction in first 12 hours, radial approach was associated with a significant lower incidence of major bleeding and access site complications and with a significant better net clinical benefit. Moreover, this approach reduced significantly ICU stay and contrast volume compared to femoral approach, and our results support the use of radial approach in primary PCI in experienced radial centers as a first choice. Thank you for your attention.
Thank you. Congratulations and thank you for this very important study. This paper is open for any questions from the press.
Justine Cadet with Cardiovascular Business. I'm curious if you could contextualize these findings with the findings from RIVAL, and then I'll have a second question in a second.
How does it compare with RIVAL?
As I said, RIVAL was a sub-study of OASIS 7, and there was a lot of centers, I think over 150 centers there, and the number of patients which were included was 2,000. Our number is about 700, and the radial experience was very variable in this study. Our study included centers and investigators only with high experience in radial approach. And the result, of course, our primary endpoint was major bleeding and access site complications. In RIVAL trial, there was more results, including patients with non-STEMI.
And then just in terms of the volume, the operator volume, because it's so infrequently done in the United States comparatively, I'm just curious, and for the panel as well, can these results be translated in a practical way to centers across the U.S.?
I think this is an important question. We believe that the learning curve couldn't be too long in change your practice from femoral to radial approach, and when the center is experienced in radial approach in elective patients, after 1 year, I think they can start, when the crossover rate is low, they can start the program in primary PCI with good results.
Jim, that would be a good question for you to perhaps take as a high-volume U.S. operator. What do you think?
Yeah, again, congratulations. This is very important as I think radials continue to gain traction around the world and in the U.S. It's a challenge in the U.S., I think, for a couple reasons. One is that the operator volume in general is relatively low, and if we look at the number of primary PCIs done per doc in the U.S., it's probably on the low side, and so trying to translate the high volume master radialist approach as presented in this study is going to be a challenge. I think what will move the needle more than anything is as fellows come out in this country or are trained, they've got radial expertise, and I think that's what's eventually going to really change this here.
Okay. Segment?
Congratulations also, it's really fascinating data, but I missed some data on vascular closure device for the femoral approach. Were they used like AngioSeal or other closure devices?
Not all data were presented during this short presentation. In femoral group, 36% of patients had closure device.
So
is there a subgroup analysis, radial versus femoral with closure device, because then maybe the bleeding complication would be less?
At this moment, I don't have exact analysis of this subgroup, but the number of patients isn't too high.
Okay, Bert.
Yeah, Bert Cohen, angioplasty.org. The 80% figure of the radial operators in your study, is that per operator or for the center itself? In other words, when you said these were centers that did more than 80% radial.
All centers perform over 80% of PC.
But each operator who was part of this did more than 80%?
Yes.
Okay.
Right. I was just thinking that might have implications for this country, because most radial operators who do a radial in this country, even if the center doesn't do much, are doing 70, 80, 90% from what I know. So,
Okay.
When I can add something, 7 years ago, nobody from our investigators was radialist.
Yes, Robert.
Ivo, very nice study. I think certainly the findings are consistent with what we know about radial versus femoral data, that if there is a benefit to be seen, it's in patients with STEMI, and I think this certainly focuses our attention that perhaps a lot of the difference is to do with the anticoagulation strategies that's used in these patients. So in your trial, what was the breakdown of heparin? Were patients treated with bivalirudin, which perhaps has a more favorable bleeding protocol, or do you have that data?
In our study, we use heparin and 2B3 inhibitors. 2B3 inhibitors were used in about half of patients, and our study was without bivalirudin.
So I think that's an important point, and I don't want to distract from the importance of the study or the findings, because I suspect the findings would be similar, but a lot of the differential was driven probably by 2B3 inhibition.
Especially in the femoral arm.
That's the point of making, exactly. So that's an important point for us to consider.
So my question, I have two questions. One is the quick one, door to balloon time, very important and obviously because of the radial concept and the ability, was that the same between the two groups?
Yes.
And what was the door to balloon time?
Always also very important point. At first, I must say that in my country, we don't use thrombolysis. All patients are treated by primary PCI over 10 years. It means our national system of STEMI patients is very sophisticated, and our door-to-balloon time is really extremely short. In our study, it was about 30 minutes in both groups.
Wonderful. So my second question is more controversial, and I think it raises some questions. Everyone knows that in the rival study, the STEMI population actually enjoyed a benefit in reduction in mortality. In your study, which was not a sub-study but a full study, you showed absolutely no difference between death and MI at 30 days. Which do we believe?
Mortality in our study was 2.3% in radial group and 3.1% in femoral group. It's not too much different in comparison with rival, but the number of patients in our study, which was not powered for mortality, but for primary endpoint, which was mentioned, means that results were not statistically significant. But when you see to numerical results, it looks very similar.
Okay, yes.
One of the concerns about these studies,
Speak into the microphone, please.
one of the concerns is, as you become very good at radial, do you think you get de-skilled at femoral, so that when you did your trial, that you were de-skilled, when you were randomized to femoral, you were doing something that you didn't do very often?
That's a good question.
But as I said, 7 years ago, nobody from our group was radialist. And when we started our study in October 2009, there was no data from big, large, randomized clinical trial about this now clear thing as a bleeding and exercise lower complications.
So there's no question, I think, that there is no hematomas in patients who had radial access, so which is very, very good. Well, thank you very much. If there are no other questions from the call, and anybody else have any last questions, last comments? Thank you all. Thank you all for being here, and thank you for the presenters, the panel, and we look forward to a great session at the late-breaking trials. Thank you.